Our next speaker, Dr. Shashwato Mujumdar, consultant physiatrist, SCH Clinic, Kolkata. His topic is vaccination in inflammatory joint diseases. Very important topic.
Good afternoon, everyone, and my teachers, my colleagues, my juniors, everyone is here, and so many new faces as well. So my topic is vaccination in inflammatory joint diseases. As you see, it's a huge topic. We can spend the whole day on this topic only. So I'm going to be a very practical, direct guide to what we can do in case we are managing these cases. So the basic principle involved in this particular thing is that the vaccination is strongly recommended because the inflammatory joint disease and the immunosuppressive therapies, they increase the infection risk. And inactivated vaccines are basically safe with all DMARDs and biologics and JAK inhibitors. The live vaccine should be avoided while on most biologics and immunosuppressives. If possible, administer the vaccine before initiating the immunosuppressants, ideally 2 to 4 weeks prior. This is a common practice that we do, all of us do here. So the vaccinate ideally when the patient's disease status is stable, but they do not delay the essential vaccines during flare-ups unless live vaccines are required. Vaccination does not worsen autoimmune disease activity. This is the EULAR's stand on this. So we have to be a little bit cautious. So essentially, because autoimmune diseases, they are diseases associated with the immunity. So once you induce the immunity in a positive or a negative way, it is going to affect the patient. So the disease activities can increase or decrease depending upon what you're going to do. So the inactivated vaccines that are usually utilized in these patients are they can be given anytime, or even on DMARDs, biologics, or JAK inhibitors or steroids. So influenza is annual vaccine, which is strongly recommended annually for all IgD patients. Prefer the quadrivalent inactivated vaccine. High dose vaccine is preferred in patients above 65. Pneumococcal vaccine is ACR strongly recommends this in pneumococcal vaccination in all IgD patients. Preferred schedule as per the 2022 latest guideline is option 1 is PCV 20 single dose, or PCV 15 then PPSV 23, which is after 1 year, 8 weeks if there is a high risk. And COVID-19 vaccination nowadays, it's a very big issue. So we have to follow the national protocol on this, but booster doses are recommended in those immunosuppressed. Hepatitis B for patients with risk factors or before starting rituximab, particularly use a standard 3-dose schedule, which is 0-1-6 months usually, and in an accelerated schedule if needed, if you want to introduce the medication earlier. Then HPV vaccine, which is strongly recommended up to the age 26, may consider in the 27 to 45, that is reproductive age group. And then tetanus and Tdap, which is a standard adult schedule, is to be followed, boosted every 10 years. Wound management and in using another dosage of Tdap or IVIG as per standard guidelines in case of an injury. And shingles, this is something that has been put into the focus. So herpes zoster recombinant vaccines, primarily the preference is Shingrix, so which is preferred non-live, recommended for patients above 50 years and adults above 18 years on immunosuppressants. And hepatitis A meningococcal typhoid vaccine, which can also be given depending on the exposure. Now, live vaccines, we have to avoid the live vaccine in the following, particularly biologics, TNF inhibitors, interleukin-6 inhibitors, and so on. We are particularly concerned about rituximab because rituximab is something that sort of changes the immune profile of the patient on vaccinations. For example, tocilizumab doesn't really involve the immunosuppression in that way that the vaccine response does not get suppressed. But rituximab will suppress the vaccine response. That's why all the vaccines in case of rituximab are to be given 2 to 4 weeks prior. So JAK inhibitors is another something that we are these days using very commonly, even without indication in some cases. Cyclophosphamide, high-dose steroids when it's more than 20 mg per day for prednisolone. If unavoidable, stop the biological JAK inhibitors 1 dosing cycle before and wait for 4 weeks after the vaccine. And for rituximab, give live vaccine 6 to 12 months after rituximab and 4 weeks before the next cycle. In case of immunosuppressants, for example, methotrexate is a very common one. For influenza vaccine, consider holding methotrexate for 2 weeks after vaccination, which is an ACR recommendation, and continue methotrexate with any other vaccinations. Rituximab, I've already explained. TNF inhibitors, interleukin-6 inhibitors, and so on. Continue during all inactivated vaccines. JAK inhibitors, tofacitinib particularly, this is continue for all inactivated vaccines. Hold 1 week around live vaccines if unavoidable. And steroids, avoid live vaccination if on more than 20 milligram prednisolone per day. Then the pre-biologic screening, this is something that we are supposed to do these days. Most of us, we do. So focus for varicella immunity, MMR immunity, hepatitis B and C, and TB screening, which is not a vaccine per se, but you are supposed to check that as well. Live vaccines can be completed 4 weeks before starting treatment. In pregnancy, all the inactivated vaccines are safe and recommended. Live vaccines are contraindicated. In case of elderly, we have to go for high-dose influenza. PCV20 is preferred. Shingrix strongly recommended. So in any case, in any inflammatory joint disease, we have to give 3 different vaccines in every case, basically. You have to give pneumococcal, you have to give the Shingrix, and you have to give the influenza. And influenza you have to do every year. Remember that. Thank you. These are my recommendations.
Thank you very much.